Good evening. So I would like to welcome everyone to today's very, very important topic regarding nephrology. And this is, as usual, IHN Fireside Chat, series number 31. And today's topic is prevention and early detection of kidney disease in Africa. We are lucky to have a very good presenter from Ghana this time. His name is Dr. Elliot Tannor. Is a senior specialist physician and consultant nephrologist, Department of Medicine, Renal Division, Komfo Anokye Teaching Hospital, Kumasi, Ghana. He's also a senior lecturer, School of Medicine, School of Medical Science, Kwame Nkrumah, University of Science and Technology. Dr. Elliot is also a chair of AFRAN, Young Nephrologist Committee, and is a director and the founder of Kidney Health International. So he'll be taking us through the prevention and early detection of kidney disease in Africa. And this is a very, very important topic in Africa, especially, we know Africa, we have a lot of issues regarding early detection, regarding early prevention, detecting the risks for development of kidney diseases. We have the issue of finance, the issue of knowledge. So I don't want to preempt what Dr. Elliot is going to talk about, but I think he'll talk us through a lot of issues regarding prevention and detection of chronic disease, kidney disease in Africa. So Dr. Elliot, you are welcome.
All right. Thank you. Thank you very much. And thank you all for the opportunity and the invitation. I'm so always excited to be talking about prevention and early detection. Just for clarity, how many minutes are you giving me? Because when I'm talking about prevention, I can talk the whole day. So I don't bore people. So are we doing what, 35 or 40?
Yeah, so 35 to 40 minutes. And then after that, we have a question session.
Okay.
Yep.
All right, so that's fine. So thank you very much. And thank you. And I see a lot of people on the call. In fact, I see Prof. Anokye actually on the call. Thanks, Prof, for joining. And I know you'll be helpful during the discussion period. So we are discussing prevention and early detection of chronic kidney disease. I personally believe that is the one thing we should be talking about well in Africa and putting in structures to ensure that we pick these conditions early to be able to manage. I don't have any disclosures. And my objectives for this afternoon, evening, depending on where you are in Africa, is that we are going to just discuss briefly the burden of kidney disease globally and then in Africa, and the peculiar challenges we have in the management of kidney disease in Africa. And then, of course, prevention as a tool to decrease the burden of kidney disease, early detection. The big question is, who should we screen and who should we not screen? And I think that's where we'll talk a bit about more. And I'll just give you a little case study of some work that we are doing here in Ghana, a little small way to help pick up kidney disease early. So as we know, generally about 1/10 of the world's population have some form of kidney disease. And indeed in Africa, Stellenbosch showed about 13.9% of us have some form of kidney disease. Indeed, if you look at the disparities so far as North, South, East, West, Central Africa are concerned, Northern Africa seems to be well spared so far as this study is concerned. The West is actually West Africa, from where we come from. And indeed, East Africa, you're also having your fair share. And then Southern Africa, indeed, follows, in fact, Middle and then Southern Africa follows in that order. 15.8%, this study that is actually a later one to what Stellenbosch actually showed. So clearly, kidney disease is a big problem. And indeed, we need to look for ways to manage it, look for ways to prevent it, in my opinion. And that's why this discussion for me is important. In essence, what are we talking about when we are talking about kidney disease in Africa? Over 850 million people worldwide have some form of kidney disease. Unfortunately, when we are talking about non-communicable disease, the focus is always on the cardiovascular, and they push us under sometimes diabetes, and they push kidney under cancer and then respiratory diseases. So indeed, we don't have time to talk really about kidney disease as a non-communicable disease in itself as an entity, so far as even WHO and all are concerned. Now, unfortunately, these non-communicable diseases make up majority of the diseases. So over 55% of the disease we suffer from are from non-communicable diseases. Unfortunately, chronic kidney disease have some catastrophic health consequences. So you have a patient who is diabetic, all of a sudden has now diabetic kidney disease. And now if you are not careful, it's leading to death because now the expenditure is great. You have to be on dialysis, and most people or most patients in Africa, you know, would have to pay out of pocket for their dialysis sessions. Now we know, and that is what we need to play on, that CKD can be prevented and then the progression can be delayed. So if we can prevent the progression, then we need to act quickly to be able to. So in this article that I wrote, where I couched chronic kidney disease as a neglected non-communicable disease in Ghana. So of course, it might apply to Tanzania, to Kenya, to South Africa, wherever, because when we are talking about the big four non-communicable diseases, kidney disease is not talked about. And like I mentioned, when kidney disease comes as a complication to whatever non-communicable disease, the prognosis is worse. And again, the fact that the kidney disease itself sometimes are complications from this non-communicable disease, they also make the mortalities increase. So there is the need to always look at kidney disease when you have your cancer, to be looking at the kidneys when you have your respiratory problems or whatever, even communicable disease you are discussing. Now, the issue in Africa is clear in terms of what the causes are. Basically, the top three don't seem to change: hypertension, chronic glomerulonephritis, diabetes. But where I would want to drive your mind towards is this segment of patients who come in so late. Kidneys are shrunken. There isn't much that can be done. You cannot investigate, and some will couch as unknown. Some would couch as chronic glomerulonephritis. And I feel that is an area we need to look at, even so far as Africa is concerned. What are this? And that is why issues of CKDU is coming up. So CKD of unknown causes. And I feel there is a lot that needs to be done so far as that is concerned. Now, the issue with chronic kidney disease, unfortunately, is that the risk starts from our mother's bellies, all right? So Valerie and co put up this paper that actually goes to show that if you are starting off on a wrong foot, chances are that your kidneys might not last you a lifetime. And I believe that that is what we are tending to see in Africa, why our people are coming in younger than people are seeing in the West. So what happens? You have a mother who wanted to abort you, you got lucky, you didn't die, and then in the course of pregnancy, your mother might be malnourished, so you don't grow to full term, you are born premature, and then now when you are even born, you are starting off with low nephron numbers. You are getting your diarrheas, you're vomiting, you are malnourished and all, and then in the course of it, you are getting malaria that is hitting you. So before adulthood, you have all these insults that is making your risk of kidney disease high. Of course, before now we get older and we compete with what we normally know, the diabetes and the hypertension and so on and so forth. And that is why we need to look at this critically. So what are the peculiar challenges so far as Africa is concerned? Indeed, Africa contains about 70% of the least developed countries in the world. So we have all the poverty here, where a lot of people are actually surviving on less than $1 a day. Now, though our communicable diseases, we have our malarias, our HIVs and all, they have not gone anywhere. We are now taking upon ourselves our diabetes and hypertension in high astronomical numbers. And indeed, that double burden is not helpful so far as, of course, kidney health is concerned. And that is why we need to look at it. And that is why the life expectancy of Africans generally are low. And then now you have kidney disease compounding the problem, and we need to discuss it. Relatively young people are developing kidney failure in Ghana. And again, they believe that genetics may have a major role to play. And that is why the ongoing H3 Africa study is hoping to unravel some of these mysteries, which we are hoping to come out with soon. But the problem is that awareness about kidney disease, even amongst high-risk groups. So people have said that, listen, let's just screen those who have hypertension, diabetes, and all. But the question is that even the people who have hypertension, diabetes have no idea about kidney disease. And in any case, a lot of people who have these hypertension, diabetes are not even aware that they have hypertension, diabetes. So we have major problems so far as that is concerned. And of course, as for access to healthcare and diagnostic tools, it leaves a lot to be desired, because you have people who are being seen in peripheral hospitals, diabetics for years, they don't even check for dipstick, years, they don't check for creatinine or anything to even find out what is going on. And for me in Ghana, for instance, what I see that makes me so worried is the fact that that local physician, or for that matter, that district doctor would only think about, oh, go get a renal function test when he sees that the diabetic now has facial puffiness or some pedal edema. And lo and behold, they see what they need to see. The creatinine is in the roofs, and then they go to the teaching hospital to be seen by Elliot. And unfortunately, by the time they come, things are so late, and there isn't much that can be done. And it's actually because now even the management or picking up of acute kidney injury, even amongst our healthcare providers, is even low. So the belief is that sometimes people will develop acute kidney injury. All they can think about is, oh, creatinine is raised. So if your creatinine is raised, it's chronic kidney disease. Discussions about acute is actually less, which we believe can easily be treated, reversible, and people can go back to their normal lives. What are some of the challenges, again, that we face? The little brains that we have, so far as healthcare professionals are concerned, are flying over to high-income countries. Of course, brain drain. And indeed, it makes the healthcare providers reduce. So nurses, doctors, not to talk about the very few nephrologists we have in this country. And again, if you have a high-income country where they are able to look at the budget, you see chronic kidney disease and its management, when you are treating only about 0.03% less of the population, it is eating about 3% of the budget that is for health. And that is why most African countries, the politicians will not want to think about the management of kidney disease, because it makes sense. They will look at the fact that, well, putting some patient, somebody on dialysis for a day can treat about 100 people for malaria. And you know the politicians will look at numbers. Because of that, our dialysis treatment rates are so low, so low. Renal replacement is a big problem. Here in most part of Africa, in Ghana, for instance, and I believe in most part of Africa, most of our patients don't survive 3 months on dialysis because they are not able to continue care. They run out of funds. They are doing twice a week dialysis. Indeed, PRN dialysis sometimes. I have patients who come and they get breathless. They come and get a 4-hour session. They disappear and then come in 2 weeks or 3 weeks when they are feeling very sick. And it's so disheartening to see this. Low PD patronage. Indeed, we don't look at PD as a form of renal replacement, which is sustainable enough to be able to help in terms of the management. Low transplant rates, the numbers are so low. Most of the people would have to leave the shores of Africa to go get transplant done in India and all. Only a few countries in Egypt, in South Africa, Kenya, Nigeria are able to manage some form of renal replacement. So practically, you and I know that we watch most of our patients die on daily basis, and that is very, very disheartening. Now, renal replacement, so far as transplant is concerned, cost is an issue, so most cannot. Those who can manage to travel even to get their transplant done would not be able to get kidneys, because you know most people in Ghana, I believe in most part of Africa, want to die with their full set of organs. You know, so to give you one kidney and believe that I will survive, it's a place that we need to put a lot of information, or for that matter, education. And that is why most people would prefer to keep their full set of organs and not donate even to their loved ones. And because of that, most people stay longer on dialysis with poor quality of life. So the nephrology network, a global workforce, is actually so disheartening. You look at this beautiful chart where the Europeans have a lot of nephrologists per million population, and look at Africa, less than 1. So I decided to focus the lens on Africa, and this is what I found. As per this study, most African countries are actually doing less than 0.9% of per million population per nephrologist. So there are very few nephrologists per million population. The latest data we have for Ghana is about 0.26. So as compared to the study that was done now as of 2016, all we have increased is 0.26. It is still very low as compared to the rest of the world. And thank God for ISN training, for which some of us are beneficiaries. And we've come back to Africa to see how best, or come back to our various countries to see how best we can help in the management of kidney disease. And I owe all I know and all the training to ISN for what we know so far. And indeed, if you look at the numbers, before 2000, only a few fellowships were done. Now, between 2011 and 2020, the fellowships have increased. Education ambassador programs have increased. And all of these things is to boost the nephrology workforce. And indeed, ISN is doing so well. Local capacities we need to look at in building, also so far as nephrology workforce is concerned, because we need some important number of people to be able to see the kind of care in the practice of nephrology that we want to see. Now, how did I end up in all of this? I came back with all the excitement. I'm coming to do the best I can to save my people. And I realized that virtually on a daily basis, you are watching people die from want of renal replacement therapy because they cannot afford care. And it was so disheartening. And this case of Sarah Menu, she was a 16-year-old. I was called to see, then she had come in the ICU, intubated. And indeed, I remember so well when I was walking into the ICU, there was this mother who was out there crying her heart out. Apparently, she had been told that Sarah needed dialysis to survive. And indeed, she was a poor widow, just a farmer. Her husband had died, and she had no way to raise this money. And then I asked more questions, and it so happened that, oh, Sarah was told she had hypertension about a year or two ago and did not follow up, of course, again, because of cost issues, again, because of lack of knowledge and all. And now she's about to die. Sarah, I understood, was a very brilliant young lady who wanted to be a nurse. And indeed, the hope or the future of such a beautiful young lady was dashed just because they could not afford dialysis. I became uncomfortable. And then we decided to look into our own data locally. And we realized that our outpatient cases of kidney disease had increased over the past 10 years. So this was some retrospective data of what we collected in the hospital using hospital data. Admission had gone up by 3%. And the worrying aspect is that when people come in with diagnosis of kidney disease, they normally will come in very late, and up to 50% will die on admission. That was so worrying. And we got to know that the quality of life of our patients was poor. Now, what is the situation so far as kidney disease is concerned? In Africa, like in Ghana, like most part of Africa, for example, in Ghana, 47 years was the mean age by which people are getting kidney disease, 47. Elsewhere, it is 60, 70, and so on and so forth. Now, what did we realize? Like I said, over 70% will come in end stages. All right, so they come in, and then first thing you are talking about, you do their ultrasound, shrunken kidneys, hypertension in the roofs, HBs on the floor, and they need dialysis to survive, like Sarah's case. She could not afford, and we watched them die, and we signed death certificates. And the data I showed you of the people dying are those who die on admission. Those we discharge because they are a bit stable, and they die probably a day after or a week after, and they don't come back to the clinic, are not accounted for in that data. The numbers are huge, and I believe similar numbers are seen across Africa, maybe sub-Saharan Africa, I should say. Poverty is a major issue. Poverty is a major issue. And of course, even the patients who can afford dialysis, the quality of life is so poor. Now, I decided to look and investigate and try and find out what is going on. What I noted was that knowledge about kidney disease was poor generally. Healthcare providers lacked the adequate knowledge to be able to pick patients early enough, even for high-risk patients, and refer appropriately. Acute kidney injury, like I mentioned, is less discussed of in the peripheral hospitals because they will not look out for it, basically to manage them appropriately. And we believe that some of these patients might be discharged, they come back later, and then they might develop chronic kidney disease in the long run. And we need to be looking at these. And then, of course, the poverty issue was a big problem. So now if money is exchanging hands for care, what do we need to do? Advocate, talk to governments and all to see how best they can help our patients. The question is, as nephrologists, I now saw myself in this situation where it looks like we are spending all our time actually pulling people out of the drowning river. But the question I ask myself is that, why are there so many people falling into this river? And these people who are falling into this river, are they not preventing kidney disease enough? Or what effort are we putting into preventing kidney disease? Why are they not taught how to swim? In any case, equity issues come in the management of kidney disease. Universal health coverage at least would have made it possible for that diabetic hypertensive to get normal creatinines done, let's say 6 months, every year, to be able to pick these conditions. And then the question is that when they fall in, where are the life jackets to keep them alive? There's no equitable access to care. And that is why we are tending to see these patients die. And we keep getting tired as nephrologists because we keep pulling people out of water when we are supposed to actually prevent them from falling into the river in the first place. So I ask myself, and I ask all of you on the call, what can we do as healthcare providers? What can we do as nephrologists? So probably, are we too late? Or maybe we need to have started a long time ago. But I believe we are probably a bit behind because some people have taken the head start in terms of the education. And unfortunately, sometimes they're educating our people wrongly. So here in Africa, you sit in a bus or you listen to your normal radio, and it's all about ways to cleanse your kidneys, ways to prevent kidney disease. So, and they are pumping all sort of herbal medications into your patients. And indeed, are we not the ones to be educating our patients so these ones don't have the opportunity to brainwash them into wrong things? So probably we are getting a bit late, but the time to act, I believe, is now. Because if we don't act, we'll see most of our patients develop chronic kidney disease into end stage, and most of them will not have the luxury of comprehensive or dialysis and renal replacement. So our target should be what? Into more of prevention. So prevent the kidney disease, pick it up early, and prevent the progression. If we don't do that, unfortunately, all we'll have to be grappling with, like we do now, is conservative care. They come in and it's conservative and you watch them die. Thank God, ISN's vision is more into promoting kidney health. So in the vision and in the values, I actually see more of sustainable kidney health. So I believe that we should not wait for the disease, but rather we should look for ways to prevent the disease. How active you are managing your diabetic to ensure they don't develop kidney disease. How active you are following your hypertensive, and of course, educating them to prevent kidney disease. I believe that is the way to go. Awareness creation is so much lacking in this country. Awareness creation is so much lacking across Africa, and we need to take the forefront so far as education is concerned. And belief is that even for high risk conditions, diabetes, hypertension, this study shows that they know less about kidney disease. Even in about less than 10% will know about kidney disease. And that is why we need to keep on reminding our patients, keep on talking to people about kidney disease. And that is why screening plays a significant role for early detection so we can prevent the progression. Lack of trials to evaluate the screening and monitoring of kidney disease indeed is something that is stopping most of these activities, because it's believed that universal screening is not helpful. There's a lot of truth in that, but as we proceed, we are going to discuss. So how do we prevent kidney disease? I believe that if we target the first box, that will be exciting. Is my patient obese? Is my patient diabetic? Does my patient have hypertension, polycystic kidney disease? Does the patient take too much salt, protein? APO1, like I mentioned, H3 Africa coming up with. So these are the risk factors we should be looking out for. Are we asking our patients if they know what their birth weights were they born premature? Because we believe all of these things are risk factors. Our patient with prostate disease. So the point is that any condition that we believe has a link to chronic kidney disease, we should actively be looking out for them and preventing them from getting the kidney disease in the first place by managing them. If we pick the kidney disease in the early stages, then secondary prevention comes in, because there's adequate information, there's adequate data to show that when you pick up early, of course, BP control is key, protein losing, reducing the protein loss in your urine is key. SGLT2s are now all over the place. That is another big issue. We've talked about it nicely. The data supports it. How many of my patients with diabetes can afford SGLT2? That is a discussion for another time. But at least ACE inhibitors have been with us, and we need to pick up our diabetics early, microalbuminuria, put them on medications to ensure that they don't develop overt proteinuria, and of course, kidney disease. And of course, tertiary prevention is key, but then these are the ones we are tending to see, and we need to focus on the period before all of this. Unless, if we don't do that, then unfortunately we run into trouble, and then the only thing we can be discussing is renal replacement, which for majority of people, they cannot afford. Then the question is, how can we maximize primary prevention when most people are not even aware of their own risk factors? So you have a diabetic, hypertensive. In fact, I joined the May measurement screening where we're screening a lot of people. And indeed, a lot of people that you pick, over 60% of patients who had hypertension had no idea that they had hypertension. So the question is, if we are waiting for this hypertensive to come to us for us to screen them for kidney disease, believe you me, we'll see what we are seeing. We will see them come with kidney disease in advanced stages. A case for early detection. So this paper is by Kedigo, it's all over the place, where there are clear cases that, listen, we need to. So for us in low and middle income countries, we virtually don't have a choice than to prioritize prevention and early detection. And I'll just summarize the controversies conference in terms of their conclusions, basically. So their conclusion 1 to 3 are the ones that we know of, all right? Know your diabetic, hypertensive, and screen them. Put up programs that will help to pick up high risk factors, and that's why high risk individuals. And that's what I've mentioned earlier on, that people don't even know they are high risk. They don't know they have hypertension, diabetes. So if we are waiting, then we'll run into trouble. Then the initiation and frequency and cessation of CKD screening should be individualized. So if we are talking about individualization, it is key that we look at our environment and be able to ask ourselves how we can individualize the screening so far as the care of kidney disease is concerned. But then I'll bring your mind on to the last part, where they mentioned that the 12 and 13, CKD screening in high risk is likely to be cost effective. So most of the studies show that if you screen high risk people, it's cost effective. But I'm asking myself that if you don't even know you're high risk, then what actually happens? And the test that will cost you, let's say for maybe about $5 or so to run a kidney test every year, vis-a-vis you waiting 3-4 years down the line, patient now requiring dialysis that costs an arm and a leg. Which one might be cost effective, depending on what you are comparing with. And the last part is that CKD screening approaches may differ. So now they threw it at us that, okay, for low middle income countries, maybe you might have different opinions so far as this is concerned. And I think as Africans, we need to look at it clearly and ask ourselves the way to go, maybe as AFRAN. And indeed, I've been sharing this toolkit, which was just released not long ago. And indeed, the summary of this toolkit is that geographically targeted screening of unique at-risk population should be considered. So it is important that if we feel that we are tending to see our patients coming with kidney disease early, let's not wait, because most of the studies will say, okay, screen them when they're above 65. Now, my average patient gets kidney failure around 47. Should I wait for 65 before I screen? Maybe I need to screen a bit earlier. What is the age that might be cost effective? Is it 30? Is it 40? And these are the things we need to have our own controversy conference to be able to come up with, because I believe that we need to look at these numbers a bit differently. If you have a patient who, of course, has a family history of hypertension or polycystic kidney, then of course the screening post 20 years might be necessary. And again, because of the lag time, which needs to be discussed. So these are some of the key things that should inform us. So should we go beyond targeted screening? And this I'm asking all of the people on the call or all who will be watching later. Low and middle income countries are ill-equipped. We don't have the ability to pick and manage cases when they develop late. In fact, most pundits have even suggested that the screening should go beyond just diabetes. So pre-hypertension and pre-diabetes. So now there's a call to consider even those who are about to get the diabetes. So, and that is why I feel that maybe, yes, we also need to go just beyond targeted screening. Universal screening, most people have believed are time-consuming, expensive, and not cost-effective, like I've explained earlier. But then the question is that if we are seeing CKD of unknown cause in most population, is it worth screening these people universally or probably as a group? I think it's open for discussion. The question is that, will universal screening be beneficial in Africa? So I'm throwing this out there because, of course, we have lack of awareness about the high risk, like I mentioned, because of early kidney disease developing, like I mentioned, because of all this herbal medication that is being used, which I believe is contributing to CKDU, abject poverty, primary health workforce who are supposed to be seeing these diabetics and hypertensives and screening them are leaving the shores. The few probably don't have time to think about your kidney or do dipsticks for it. Now, in equity, there are rural areas with no healthcare. So they walk around with their hypertension, diabetes, and only come when they are in uremic encephalopathy and all. Is that what we want to see? And essential medicines and diagnostics. Nick is here. We are having a big discussion with the emerging leaders to try and find out how to deal with essential medicines and diagnostics as a way to be able to prevent or manage kidney disease. But then the big problem is that there isn't accessibility because of lack of funds and even availability and all. Am I making a case for probably some universal screening? Is it strong enough? But I think we need to have a conversation about this. And this summary paper summarized that screening of CKD should be a policy priority in low and middle income countries, as early intervention is likely to be effective in reducing the high burden of and morbidity of kidney disease. So I believe that we need to have a conversation. We need to be active in following our patients, in asking them, or probably doing some universal screening for people in high risk areas, or for that matter, because of the prevalence that we are seeing. Is it worth considering? Can we make a case? Because maybe if we make a case for government, listen, for a particular year or once a year, if you can screen X number of people, they push some money in, we pick up these people, we can follow them, and we can probably prevent progression. It's something that is worth discussing. So for us here, so probably I'll finish this in the next few minutes. For us here, we try to have some form of campaign one way or the other to increase awareness, because like I said, one of my major problems was the fact that people were not aware of what is happening. I mean, they know about diabetes, they might know about hypertension, they know, everybody now knows about COVID, but still people don't know about kidney disease. So we need to go out there and make a lot of noise about kidney disease. Educate healthcare providers who are seeing our patients early enough. They see our patients every month. They see our patients every 2 months. They see our patients when they develop malaria, when they develop preeclampsia and all. we need to educate them that they need to be mindful of these kidneys. Our surgeons are now operating without even checking for renal functions and all. And indeed, sometimes they call you to come and see a case and you ask them, did you do renal function before? They didn't, and we ran into trouble. So this education is very, very important. And of course, to research more locally brewed research that would help us to come up with the data that we require. Now, we've gone around a lot of radio stations, myself and my team, and the one radio station, thing that I would mention quickly is that when we go into advocacy, we go into health promotion, let's get our patients involved. So this patient of mine, I mean, unfortunately, he passed last year. He was on dialysis for about 4 years. He was still looking for funds for transplant. He didn't, and he passed on, sorry. That is Ayaba Kofi. He would love to educate people. He said he was meticulous about his health. He knew he had hypertension. He would go and check his hypertension, but he never was checked. The kidney functions was never checked. And like I said, the first time they decided to check the kidney function was when they realized he had developed pedal edema and facial swelling. They referred, and his creatinine was in the thousands already. So now that is the problem. That is the ordinary case that we see. So he was like, listen, Elliot, anytime you go on any radio station, I'll be happy to come with you to tell people my story so people will learn from it. And I believe it's also such an effective tool in the management, or should I say, in awareness creation. We visited a lot of radio stations, television stations also discussing kidney disease. Bring the opportunity and we'll discuss kidney disease. And I'm encouraging all of us, make some time of our clinical schedules, make some time of our normal duties and engage the media. What I realize is that if we don't engage the media, others do engage the media. And unfortunately, they go there to sell their herbal medications, which we believe some of them have effect on kidney disease. So we need to engage the media. And indeed, Vodafone invited us to talk. And indeed, it was actually telecast on about 10 radio television stations, which had a lot of impact because I got a lot of calls. I got a lot of feedback from what people heard that they never knew anything about. So you and I know a lot, but the people just beyond our hospitals know very little. We need to be going out there. Is it a church? Is it an organized group? Is it a corporate? Wherever there is some opportunity. In fact, when EcoBank invited, basically they wanted us to come and talk about non-communicable diseases. Their target was actually cancers. And they gave me the mic and I took advantage to talk more about kidney disease, of course, because that's what I'm passionate about. And this is actually one that excites me so much because this patient, Emisa, was 23 years old. He had lupus, which was poorly managed at the periphery. He came in end stages with lupus nephritis. We started him on dialysis. He died from complications of lupus. And indeed, the father got to know a lot of things and felt that, listen, doc, I think you should talk about kidney disease. And during the funeral, if you don't mind, come and talk to people about kidney disease. So we are invited to a funeral to actually, indeed, in Ghana, if I give you the premise, most people will not give you a mic at funeral because it's a time that they tend to get a lot of money, sympathizers and all. So that mic is very expensive. But some people to say, come on, come and talk for about 30 minutes on kidney disease. And that was helpful. And guess what? The chief who was standing by afterwards sent some people to where I was sitting to tell me that, well, the chief wanted to see me. Apparently, the chief had some pedal edema and so on and so forth and had a lot of questions and we had to follow up. So I believe that these things have an impact and we need to be doing that. Social media is buzzing. And again, I mean, most of us on this call are on social media one way or the other. And nuggets here, information there goes a long way to help put that message out there and to help diffuse the wrong message about kidney disease that is already out there. And we have a group called Healthy Kidney Facebook, and it's seems to be getting a lot of members. We already have about 2,800 members already, and I try to throw messages there to educate them about kidney disease. Now, I mentioned that the healthcare providers at the periphery are not picking up cases well. So what have we done? Volunteers, and we are all over the place, and I encourage all of us to be a part because I feel it's helpful. If you're able to pick 2-3 people with hypertension and refer them appropriately for continuity of care, I believe it's going to be helpful. World Kidney Day has always been my passion ever since I came back, and we don't joke with it because at least walking on the street, somebody will ask, oh, what is the kidney? Oh, what does it do? And all, and we try to educate them. Of course, now COVID bounced and we have been a bit slow, but even this year, we took advantage to get volunteers, and social media has been buzzing with information on radio, television, we've tried to do. Now, we've written a lot of articles also, sometimes, you know, some of these things. So those who want to read, can get some valuable information to read in simple layman's language. So, doctor, in fact, what I actually do is that when I hear a question in the consulting room, I believe 1,000 people don't know this, all right? So how do I get them to know? Somebody asks me, oh, doc, you're saying my kidneys have failed. Is it one or all? And you have to explain to them that both work together and on and on and on. So I was like, let me write a little piece, throw it out there for people to read about it, obesity and kidney disease, hypertension and kidney disease, and so on and so forth. And indeed, we had an invitation to Uganda by a missionary group, indeed, and this was non-COVID time, so it was some time ago, and the kids were all excited. Well, it was a selfie time. The point is that I believe that we need to go out there with all the information we have. During COVID, less work, took time to finish off a little book I had started writing on the 10 common questions I kept hearing anytime I go and do a talk on kidney disease. I was like, let me put it in a little material where after the talk, people can have a book and read to get some information and be able to share this information. So we wrote a little book on the 10 most important things everybody should know about their kidneys, how to prevent kidney disease, which is actually going so well so far here in Ghana. So it's all about Kidney Health International, and this is what we have been trying to push and advocate for. If you know people who can support what we do, or you are in your own country and you want to get some help on how to do this, we'll be happy to support you with the little knowledge that we have. And indeed, free screening sometimes we try to do during days. So in conclusion, kidney disease is very common. There are low nephrologist workforce in Africa. Most people report so late, and that's why we need to get to them before they report late. Unfortunately, majority of our people cannot afford care, and we have to be realistic about this. There are huge equity challenges in the management of kidney disease, and that is why I believe that awareness creation, health promotion, and liberal screening is suggested. Thank you very much.
Wow, thank you very much, Elliot. That was excellent presentation. And you touched almost all the important areas regarding prevention screening of CKDs in Africa. So we'll be going for a question session, and I'm ready to hear any questions or comment from the audience. Anyone with a comment or question? Yes, Dr. Lloyd.
Thank you, Dr. Elliot. That was a wonderful presentation. I think you covered a lot of ground and wonderful ideas too. I mean, using, screening high-risk populations and creating awareness, organized groups, educating people, social media, using, I like the word misengage, allowing people to misengage. That's something very important, engaging the media. Thank you very much. Wonderful ideas. So I think Nick has been doing some work. We also have, one thing that we do at AHN is screening the lab. A lot of tests that are done in the lab, actually, if you screen patients who have a low GFR from the lab, we do get patients who have CKD and are not really followed up. So that has been one additional thing actually that we've actually found very useful from our practice. That is, once you go into the lab and every day collect that data, and the details and put them into a sort of a registry, and then follow those people who we have the creatinines, and then probably schedule them for a follow-up if it's possible. Quite often we do have problems in that patients may not be able to come from afar, or may not be able to do tests, but at least whatever can be done, I think can be done. Besides, of course, screening high-risk populations wherever we can. And like, for example, social gatherings or in churches or organized groups, as you said. Thank you very, very much. Again, the other very important thing you touched on, I think, is the CKD by herbal medications in Africa. And that's something we find quite often and a very important aspect. So again, as you said, again, engaging the media, I think is a good way of tackling that. And Dr. Egina has actually started doing that. And we hope that we will be able to do that in a successful manner. But thank you very, very much for your wonderful presentation and excellent ideas. And we would be able to take a lot of your ideas too. Thank you.
All right, thank you very much.
Before you get to talk, I'm going to later on to Lloyd's point. It was interesting, actually, about 10, 15 talks ago, Andy Levy came and presented about GFR. And he had done a survey on the labs, both private and public, in Africa that we use through our network, everyone who joins these conversations. And the biggest thing we saw was outside of those who use Lancet laboratories, none of the labs auto-calculate EGFR. And how amazing would that be? And so I think all of us have to also just align on the fact that we need some sort of open source software that can directly integrate into the labs to calculate. So whenever a printout comes, it immediately flags if a patient is stage 3, 4, 5, or stage 1, 2, 3, 4, 5, whatever you want to call it. And it may not be an exact science, but at least it's going to give us a lot more information. And it was really interesting because you could see when you look across Africa, it was really only in the countries where Lancet laboratories or large lab chains that were privately run had a strong presence where this data was actually being captured and presented in the lab results.
Yeah. All right. So thanks, Nick. But so I guess yes, the idea of screening the labs is key. But I guess the one thing we should be mindful of is that you might have some acutes also sitting in there. So I have a feeling that might be a major confounder. Indeed, I keep saying that sometimes universal calculation of GFR indeed gives a lot of people heart attacks. Okay, so our patients sometimes come, they say, my GFR is 6, you know, and then you pursue and it's probably some UTI or probably they just started some AC inhibitor and you pull it out, you follow them, they hydrate themselves, and indeed it corrects back to normal. So it becomes really tricky just, you know, looking at labs and using their creatinine to calculate GFR. It might have its challenges here and there, but I think it's a good way to, maybe we have some history to attach to it to assume that, okay, these are consistent, stable creatinine, then that would make a lot of sense. But if it's an isolated, I had somebody go check at Lancet and maybe it's 1,000 and we assume, you know, it might have a little confounder, but I think it's a great idea. No,
I fully agree. It cannot be an isolated event. I think too many people use WebMD to self-diagnose these days. So absolutely requires the likes of yourself and others to consider the other factors.
Sure.
Okay, yeah, so yes, please, go ahead. Go ahead.
Okay. Hi, Elliot. This is Bhima. I'm talking from. How are you, sir? I'm fine. It's nice to hear you. Good. And I really want to congratulate you on giving a wonderful and really inspiring talk. I mean, that's really, really great. And
thank you.
But you know, I'm a pediatrician and we have a small voice, but we want to make it heard. Okay.
Yeah, I agree.
Just to tell you that whatever you said is great, but remember, it starts off in childhood. Okay,
that's right.
And a lot of it, and you made that point that, you know, we have these pregnant women who go through malnutrition, they have preterm labor, they have a low nephron mass, etc. And so it's going to be my turn next week to be in the hot seat. And so I'm going to give a talk on hypertension. I don't want to preempt what I'm saying, but just to tell you about chronic kidney disease, that I think a lot of what we are seeing is, and in our hospital, we are seeing at the tertiary quaternary hospital, we are seeing a lot of nephrotics who are FHGs now.
Yeah.
And we did genetic studies, etc., looking for, you know, genetic mutations. And in fact, one of our PhD students just published on it, and we found only about 20 to 30% can be explained on that. So what's happening with the rest? And that's one of the commonest causes, beside obstructive uropathy, that's causing chronic kidney disease for us as pediatricians. And my gut feeling is that we are seeing a lot of what we call adaptive FHGs. That's the term we just coined, okay? And that is where these kids have other lifestyle problems, not only malnutrition from undernutrition, but also malnutrition from overnutrition, obesity, hypertension, and everything else. And I think, you know, if we really have to start education, we have to start targeting schools as the first line. You understand me? And we have to start working on, you know, good nutrition, you know, exercise, good staying away from illicit drugs, smoking, and alcohol abuse, etc., which we are seeing in adolescents. And a lot of these things are playing a major role, I think, in not just kidney disease, but all other non-communicable diseases. So, you know, it's something that we have to take into account. So by the time we see started seeing a low GFR, we've actually created, you know, we've actually long go past the stage where, you know, we should have started with prevention. We should have started with prevention long before that.
Yeah.
Okay, thanks.
Thank you very much, Prof. Thank you. It's always a delight to always hear you.
No, thank
and
you.
indeed, I always take cognizance. So normally, if there's a lot of time and all, I use the Sarah case because Sarah is a 16-year-old. So
Yes.
I actually take advantage to talk about the issue of kids. And normally that
Yes.
is how I got so worried about her situation, because I believe definitely it could have started earlier, probably in utero, or like you're saying, the adaptive FHGs. And indeed, that is actually a common thing we are seeing now. So the assumed minimal change being all common and all, I think we are now running from it because we are tending to see FHGs more among these young ones who tend to slip into adults, you know, so adult clinics for us to biopsy them. So I believe that we really need to have a discussion and how we pick them, just dipsticks across, you know, be able to, you pick some 2-3 pluses, you start following them up so we don't run into trouble. Yeah, thank you very much, Prof.
Yeah, thank you, Elliot.
All right, thank you. Dr. Naika, you want to ask a question?
Yes,
Dr. Naika,
thank you very
yes,
much.
please.
Congratulations, Elliot. I also enjoyed your talk very much, but I think we should perhaps look ahead to the next steps. I think what you've told us about the Kidney Health Initiative is very important, and it's a very exciting initiative. But I think we have the opportunity to expand this further. You know, the various AFRAN committees, and with you being the chair of the Young Nephrology Committee, and hopefully you'll have some input into the research committee, because I think all of us are doing research in little pockets. But this is something that's sort of very close to my heart, and I feel that we can really make an impact. And I'm aware, as you said, that even doing serum creatinine, even on an annual basis, is unaffordable for many countries. So therefore, I think, as Professor Bima said, we need to look beyond kidney. You know, we need to look at the basic risk factors like hypertension. For instance, when I was a medical student, we were taught that no patient should see you and not have his blood pressure checked, no matter what they came for, you know? So I think if we implement those basic things, where you pick up the basic risk factors, and then, as you correctly pointed out, try and then annually test kidney function. And I think a lot of countries are now going into universal health coverage. And I think a lot of governments are scared of us as nephrologists, demanding dialysis and transplantation. But maybe as a first step, we should say, why don't we have really good screening programs and prevention programs where the basic drugs are made available at no cost to the population? It'll save government a lot of money. So what I'm saying as a challenge to you and the research committee, why don't we take this on as a challenge for AFRAN for the next, say, 2 to 5 years? Do you
Thank you, Prof. Well taken. And we'll be coming to you for advice.
You'll be very welcome. I'll be happy to give it to you.
Hi, Salah. I totally agree with you. I think, you know, a prevention program that is going to be developed and run across the board in Africa will be one of the best things that we can do. Yes, sir?
More than anything, I agree with you.
I think that will be the best thing, rather than aiming for dialysis and transplant and everything else. You know, we should start off with prevention.
Those need to be developed side by side, but our focus should be on
prevention. Yeah,
prevention. Thank you. Thank you very much, Profs.
Yes, thank you, Prof, for very good comment. Any other question or comment? Yeah, so Elliot, probably I should comment on this regarding the way we Africans do identify and where we go when we get sick. If you do a research, small research in most of the African countries, with the exception probably of South Africa and some few countries, most of our patients, when they get sick, they go to the traditional healers. So they use local herbs, and when it fails, that's when they come to the hospitals or when they go to see the doctors. So in other fields, they have tried using the local traditional healers, and by educating them about the symptoms of some diseases. For example, here in Tanzania, we in the program of prevention of mother-to-child death, mother and child death. Normally, they are taught on how to identify risks and symptoms early before they develop those risks and symptoms. So they are being picked and then referred to the hospital. So I think as Africans, we should think in that way, rather than working as a competing, like we are competing with our traditional healers, and they think they're competing with us. They think they're better or we are better than them. So it's better we also try to incorporate them, teach them, and know the symptoms, the early symptoms, and the risks, so that they refer those patients early before they develop the disease. So if we have that approach, I think that's going to help a lot. But I know it needs a lot of discussion and on how to go about it, and acceptance of our doctors and the community as well. But I think that if that will be, that's going to be helpful a lot, because our community depends on traditional healers to treat themselves before they come to the hospitals. So that's my comment, unless you have to comment on that.
Yeah, I agree with you. But the other thing is, I'm not sure about how your local healers are in Tanzania, but I believe that generally they use us to sell their medication, if you understand what I'm saying. So they make patients know that we don't do anything. So they are the real deal, sort of, if I can say that. And unfortunately, they link up. Normally, I have some slides when I'm using for education where they assume, or they say that because their herbals are natural, they are safe for everything, so everybody can take it. And you and I know we sit at the place where patients come in very late, and they will go to these people. So for all we know, maybe GFR will be around, what, 50 something. And they go and take these herbal medications and they shoot it to, they drop it basically. So it becomes difficult sometimes to have that same platform. But I feel that it's good to start the conversation. So the university where I work, for instance, they have a department of herbal medicine where they are hoping to refine what is on the streets with with data to show whatever they are doing. So I feel, yes, those are the ones we can line up with and see how best we can help. But for me, I don't know, maybe about your side. For me, the way our herbal medication people sell their, they wouldn't want to have anything to do with you, because they say what we give are the ones that are destroying the kidneys. Can you imagine? And rather, because theirs are not orthodox, they are safer for everything, including the kidneys. So, and that is why I use that slide of are we late? Because when you hear them speak, they actually tell people that, and they have a point, because our NSAIDs are a problem. So of course, we need to talk about it. Our AC inhibitors could be a problem depending on how you use it. So they have a point. But the point is that we need to be able to let them know that information and know it well to be able to proceed. So I guess it's a long way to go. But like I said, Prof said, we have to start from somewhere. And I believe one of the key things we have to do is bring up some strong data to show how cost effective universal screening can be for Africans. Maybe most of the studies, I had some interaction with Tony, and he believes that universal screening is never helpful, but they are lucky. There are people who are in insurance every 3 months, they are going for their diabetic medication, they are running tests every 3 months. So maybe it's not effective, but for us Africans, I believe it probably might be effective, and we probably need to bring up some study, not in small corners like Prof said, but a holistic study to state that maybe for sub-Saharan Africa, we need to have a different conversation. Thank you.
Thank you, Elliot. We can still accept one or two questions or comment before end our presentation.
The issue. Sorry.
Yes, please.
I think there are more questions.
Please.
There are other questions. Other people, I think. Let them. There are other.
I think there's a question in the chat box. Maybe I'll try and read it. Leslie is saying that great presentation. Yeah, about 70% of Ghanaian patients use herbal medications. How do we streamline the herbal industry, as some herbal medicines have been implicated? So I'm not sure when the question came, but I think that was what I was trying to address. Indeed, the data I have actually shows that over 80% of Ghanaians actually use herbal medication. So, and like Kwame mentioned, it's actually the first line for most people even before they get to you. So it's a big problem. How we streamline it, we need to start that conversation. And I'm thinking that the herbal medication department in the universities are hoping to start that conversation, and we will link up with them to be able to run it. But I feel that we need to, like the CKDU issue, we've not been able to come up strongly against herbal medication, even as nephrologists. I mean, so we all say it nicely, but we don't have strong data to back it. The aristolochic acid, they've been able to show over 25 years. It took them a lot of time, but they were able to show that this causes that. But for us, if somebody brings a herbal medication to my consulting and ask, well, this one causes kidney disease, I don't have data to show. I just normally advise them that, listen, if you don't know what it will be doing to your kidney, be careful. If you know what it's going to do to your kidney, safe. But in as much as they've not written clearly that if your GFR at 60 or GFR at 40, you cannot take it, I'm afraid probably if you take it, it might harm you. So that's actually how I go about my education when I am talking to a patient. But when I'm advising people, I tell them, listen, we need to be careful. Anything we consume, whether or not it's herbal or not. So we just have to be careful. And again, you need to be seeing your doctor and checking. I mean, that's what we also advise. So those who can afford, decide that once a year, you go and do your normal screening and just check to see how your kidneys are functioning.
Thank you. Thank you, Elliot. Dr. Lloyd, you wanted to comment something?
Yeah, the other thing is when one uses herbal medications, the damage is usually interstitial, like when we see the CKDU. So it's quite often, it's not immediate. You see it after quite some time of use. So that's another drawback. You know, you won't be able to point out to say, okay, this is, and when you do a histology, you will get an interstitial picture. But by the time you pick that up, it's already a small kidney, small shrunken kidney with good urine output. There will be no edema, no proteinuria. Hypertension is not a major factor, but you've done an incidental test and you've found a creatinine which is high. So that's a picture I've seen in Tanzania, but I'm sure Dr. Elliot might have seen something different there. I'm not sure. I don't know. So this is something, another drawback that I find with herbal medication.
Yeah, you are right. We'll only get the opportunity for the acute. So there are few that we see, they go and consume, they come back. Indeed, there was one classical case I remember. He consumed, and it so happened that that concoction actually had some naphthalene in there, one way or the other. He was using to treat just urethritis. Now, guess what? He didn't know he was G6PD. Now, so he developed very bad hemolysis, came in with bad acute kidney injury. Lucky for him, after dialysis and all, he got well and went away. So sometimes we see its acute effect, but you are absolutely right. Those who are stable and they are sitting at home are having this chronic effect over a period of time. They come in, you see them, the kidneys are gone. You cannot biopsy them. They are, like you're saying, no edema, no blood pressures, creatinine is in the roofs. They are still passing urine, obviously a lot more at night. And you cannot place your finger on which herbal, because they are taking a battery of herbal medications. So which one caused what? You sometimes don't even know. Yeah. So it's a tough one, I must confess. It's a tough one.
All right. Thank you very much, Elliot.
Thank you.
Yeah, one last question from the audience or comment. Okay, so it seems there are no more questions. I would like to thank you.
Last one. What is the most effective way of reaching out to the population in terms of awareness? Dr. Elliot, from your experience, what is the most effective way? Best bang for the buck?
Yeah, so thank you for that one. I believe the way I worked around it, you need to make friends. So start from somewhere, just make friends. And the media works. Now, there are a lot of, I'm assuming Tanzania, the same. There are a lot of radio stations. There are a lot of media people. They are in your churches. They come to you. In fact, I normally engage a patient who comes to even know that, oh, one of the relatives works somewhere. And I tell them, listen, this education I'm giving to you in the consulting room, can I make time and come to your church, for instance, and then talk about kidney disease? So I talk for 15 minutes. There's somebody in the church who probably works in a radio station. I mean, how I was invited by Vodafone was a phone call because somebody had seen me do it. And they said, okay, listen, they wanted somebody to talk about kidney disease, and they know you are the one who has been talking about kidney disease. So we need to be out there and be ready. One of the things I've heard even from the media people is the fact that doctors are too busy. So even when they want to discuss some topic and they are looking for people to come to studio or now COVID, even to be online, we are busy. We are busy putting in catheters. We are busy, whatever we are doing. So I think that is actually one hitch. But I believe that if we're able to take some 10 minutes, 5 minutes, whatever it is, 5% of your time, and decide that, oh, every week, every month, every whatever thing you can afford, I will do this. With time, it's like a snowball. And that is what I'm tending to see now. And then people get to know, and now they would invite you to talk. And when they call, please try to make time to go. And now what I'm actually doing is that now it's become so overwhelming. And that's why I'm now training volunteers. So for this year's World Kidney Day, for instance, I camped about, in fact, we had an online meeting of about 160 volunteers, and in a site meeting where about 30 or so came, of course, because of COVID. And we taught them, I developed a little brochure of just salient information that they can just talk about. So you can actually hold that brochure, stand in front of your church and talk to them about kidney disease. And again, I told them, well, if they ask tough questions, tell them, okay, we'll come to them later or stuff like that. But it is working, Lloyd. I think it's working. So it's a snowball, but has to start from somewhere. Starts from somewhere.
Thank you, Elliot. That's wonderful. Thank you. That's a lesson for us. Thank you very much.
Thank you very much, Elliot. We really appreciate that. And I think if there's no more questions or comment, I think we have to end here. And I did introduce myself during the beginning. I'm Egina Makwabe. I'm the nephrologist and chief medical director of AHN in Tanzania, Africa Healthcare Network. So thank you very much, everyone, for joining us. Thank you, Elliot, for a wonderful presentation. So we'll see you next week. Next week, we'll be having another very interesting topic. Will be distributed to all of you. I would like to thank Dr. Lloyd, Nick, and AHN, and every one of you who joined this presentation today. So thank you and see you next week.
All right, thank you.
Thank you very much.